Hello, thank you so much for the opportunity to share some of my work and to introduce you to the HEROS program. Today I'm going to just first briefly go over the epidemiology of childhood cancer survivorship, convince you that survivors have unique health needs, and then focus the rest of my talk on HEROS clinical and research activities. So for children with cancer, currently slightly more than 80% of them will be long-term survivors. So a child that begins like that will look like that. And in fact, that's one of my patients who's now a CCU nurse with 2 children of her own. And this is the other way to look at what's been happening with survivorship. In children with cancer, the last 30 years has seen enormous advances in survivorship, so that for all the hematologic conditions, most of them are now curable, and we've even made strides in AML. And we've made similar strides in our solid tumors, and currently more than 2/3 of them are curable. So this means lots of survivors. But unfortunately, we have recently, now that we have all the survivors to study and to see what their experience is like, realized that cure has come at a cost. And our research studies have established that virtually every therapy is associated with a late effect. And it is specific to the therapy that was received, but almost every organ system has been described as being affected by therapy. And also there's some other collateral damage, including psychosocial maladjustment, and then neurocognitive impairment from biological reasons and social reasons. So I think an important question to ask, though, is even though these problems have been described, how meaningful are them? How meaningful are they? What is the burden really to survivors, or how much more are we seeing of this than they would develop anyway as they grow into adulthood in the general population? And an informative sample to ask this question is the Childhood Cancer Survivor Study. I'm an investigator in that study from the time I did my postdoc with Les Robison, who's the PI, but this is an ongoing retrospective cohort study of about 10,000 adult survivors of childhood cancer, and then a sibling comparison group of about 3,000 patients. And these patients are followed every 2 years with surveys and also with biological material collection. And in this study, what we did is that we graded reported outcomes by survivors from grade 1 to 5 using a standard system. And I'm going to give you some examples. 5 is death, 1 and 2 are mild and moderate, and then I'm going to give you some examples of 3 and 4 because I think that's going to be interesting. So grade 3 condition would include being deaf or blind, having cirrhosis, having gonadal therapy as a result of the therapy, of the cancer therapy. A grade 4 condition would be more severe, like having a subsequent cancer, having a stroke, paralysis, and then remember 5 is death. And we found in this cohort of about 10,000 survivors that 3/4 of patients had at least one of these conditions. 2/3 of them would have a grade 1 or 2 condition, but about slightly more than 1/3 had a grade 3 to 5 condition. And one could also think of these patients as chronic patients, in a chronic disease model, because 44% of them had multiple conditions. And then compared to the sibling comparison group, the cohort of survivors were about twice as likely to have at least one of these medical outcomes, were 4 times as likely to have one of the more severe outcomes, and were 2.5 times as likely to have more than 2 conditions. When we looked by primary disease, those patients who were most vulnerable to adverse medical outcomes were patients who had Hodgkin disease. And I think for those who know therapy for Hodgkin, that wouldn't come as any surprise, followed by brain tumor patients. And those that were least vulnerable included those who were treated for hematologic malignancies like leukemia and non-Hodgkin's lymphoma. So as mentioned, in this cohort, we were able to demonstrate that survivors were at risk for early death. And this figure here shows this graphically. If you look at the y-axis, that is the probability of being alive, with 1 being near the top, and then the scale doesn't go to 0, that's 0.8 at the bottom. On the x-axis, you see years after diagnosis ranging from 5 to 30, and the first two curves at the top are males and females in the general U.S. population. So because this group is being compared to people of similar age and gender, they're young, a mean age of 30 at the time of 5-year follow-up to 10-year follow-up. Thank you. And treated as children. In the general population, the comparison group is likely alive, close to 100%. If you look at 25-year follow-up in this cohort, about 12% of patients will be deceased. So this corresponds to a standardized mortality ratio of 8, so 8 times as likely to have an early death for all comers. The risk is higher in females, and the risk is greatest in the immediate survivorship period under 10 years after treatment, and then goes down but remains elevated. And then when one looks at the causes of the death, still about half of them are going to have a death of those who die from a late recurrence, an unusual late recurrence. But about 1/3 of them will have will die of a treatment-related complication. And then among treatment-related complications, survivors of childhood cancer are 15 times more likely to die of a new cancer than the comparison group is to die of I guess, their first cancer. About 7 times more likely to die of a cardiac cause, and almost 9 times as likely to die of a pulmonary complication. In this analysis, I was interested to see if these young people with a median age of 30 were getting adult-type cancers earlier in life, because we're just not oriented to looking for those in signs and symptoms. So this used the same childhood cancer survivor cohort to look at pathologically verified reports of second cancer in carcinomas. We excluded breast and thyroid because they've been very well studied. And we found that 71 carcinomas occurred in this group at 6 to 28 years since diagnosis. And it was interesting that, in fact, this group also did have an increased risk of carcinomas one usually thinks of with a much older population. So they're about 13 times as likely to have head and neck cancer, almost 3 times as likely to have a colorectal cancer, and about 10 times as likely to have a kidney cancer. The risk was elevated in those that had chemotherapy without radiation, but radiation increased the risk further. So this all corresponds to some other important measures. When we look at quality of life, we have some indications that as adults, these survivors are not functioning as well as we'd like, or as well as their parents would hope for them. And a couple of ways we can get this idea is, one, I just recently published that they're 20% more likely not to get married in the adult age range compared to the general U.S. population, and also to the sibling comparison group. to the end that marriage is a desirable outcome, I should add. But and by the way, we also did consider people living in same-sex relationships as married. And also, there's another study that's soon to be published that's showing that about 25% of adult survivors have meaningful cognitive impairment, especially in processing speed and memory. And this is correlated with an increased risk of living dependently, either with parents or in a group home setting. So I shared all this with you because I wanted to convince you that it is worth having a program such as the Yale HEROS Clinic. I established this in 2003 when I was recruited to come to Yale, and currently we now have patients coming from the region, from parts of New York and Massachusetts and all through Connecticut. And with this, we've established an electronic research database and clinical medical record. This clinic has also been set up so that every patient, in a sense, is being invited to be part of the HEROS Registry as a research study, and they give consent for this. And the electronic database contains very detailed treatment data as well as detailed outcomes data. We are also attempting to get performance-based neuropsychological testing on all our participants, and we're collecting sputum and establishing a biological repository. The name of HEROS really went backwards rather than frontwards. We knew we wanted to call it HEROS because that's what we think of our patients and their family members, and then we made it work backwards. So it stands for Health Education Research Outcomes for Survivors of Childhood Cancer. And a key part of the care that we provide is that we do medical record abstraction, which is very challenging to do retrospectively, but is the key information that informs screening care and anticipatory guidance. This shows a screen from our Access database, and we collect not only the names of the agents and the sites of the radiation, but exact doses. And then we also collect information about stem cell transplant, major complications during therapy, and a detailed family history, including cancer family history. We discuss our patients and try to plan the clinic visit before they come. We originally did this in person, and about last year we started doing it electronically, which has really helped. And in that way, we have the involvement of a neuropsychologist, our oncologist, a primary care doctor, and an endocrinologist that reviews all the patients' treatment exposures as well as their individual complications to design what screening tests they should have. And we also use the childhood cancer survivor guidelines that we put together in the Children's Oncology Group and that are now published and publicly available, that are based on a systematic review of the literature and scoring the literature to indicate for which exposure, what screening tests should be done, and in some cases, what consultation and subspecialty follow-up should be done. And then this is the other key part. We put their key information all on one page for the survivor and their family members to have, for their all their clinicians to have, for their school to have when they go off to college. And so in the top you see the key diagnoses. If they had had more than one cancer, you would have it for each. You would list all the cancer diagnoses and when they occurred, and then the treatment agents that were given with doses, and then a concise problem list and a focused assessment and plan of immediate follow-up that's needed. There's some supplementary pages for those patients who don't make it back to HEROS again that includes what follow-up should be for each treatment exposure so that the primary care doctor or oncologist would have that information to do the ongoing follow-up. And so currently we have about 260 patients, I say about because we did see, I think, 3 new patients today. So they are mostly, they're all diagnosed under the age of 21, and most of them are diagnosed under the age of 10, which is consistent with our incidence of childhood cancer. 45% are female, 80% are Caucasian. Of our patients, 45% of them will have multiple visits, will be seen. The rest of them will be seen and with plans given to their referring doctor to do the ongoing follow-up. And in terms of current age, most of our patients are in the adolescent and the adult range, and our oldest patient is now in her mid-50s. So we are really geared to a lot of our care towards the adult patient and engaging them to be proactive about their health and the health screening that they need. 78% of patients received chemotherapy, 46% received radiation, and 41% received surgery. This is very similar to that 10,000 member childhood cancer survivor cohort, by the way, which I found reassuring. And then in our particular sample, 36% had leukemia, 16% had lymphoma, 10% had brain tumors. We're a little underrepresented in our brain tumors. And I think that has more to do with what the population who have brain tumors and the difficulty in getting them to come back, and it's complicated by their cognitive problems, and often they're being in group homes sometimes and not in mainstream health care. And then this figure shows you what the general categories of outcomes we're finding. So 44% of our patients have an endocrine abnormality. About 1/3 have a neurological complication. 20% have a cardiovascular problem, which would include usually decreased ejection fraction or a valvular problem or arrhythmia. And then we're finding a relatively high proportion of mental health problems that would be called in the clinical range by our psychologist who evaluates individuals in each clinic. And similar to the CCSS data, there is a high proportion of individuals with multiple problems, which makes this group particularly challenging to care for. So recently, I and also Xiaomei Ma, I don't know if she's here, one of my colleagues, in Carrie Gross, tried to do a metric of what is the merit of this clinic? How much does it add over usual primary care, doctor care, or oncologist care? So we looked only at our patients that were 3 to 10 years post-diagnosis with the idea that they were the ones most likely to be getting regular care and frequent care and extra attention, and tried to establish overall, in this column you'll see the total proportion having an abnormality in that category of medical outcome, and then it's stratified in the first 2 columns by the proportion known before the specialty clinic visit and then newly identified at the visit. And an interesting pattern emerged in that definitely the endocrine problems and the other conditions that are largely clinically silent without doing some sort of blood study or X-ray study were largely, had large proportions of previously unidentified conditions. A lot of these hormonal abnormalities or hypogonadism that require hormone replacement or help going through puberty. And then osteoporosis was another category. We picked up a few individuals with cardiovascular disease that were not very symptomatic. And we picked up a lot of patients with previously unrecognized mental health problems and neurocognitive impairment. And the neurocognitive impairment also is not surprising because unless an individual had cranial radiation or a brain tumor, the IQ is usually not affected, but individuals have problem with processing speed and working memory and organizational skills, and that will lead to frustration and decreased school attainment, but may not be apparent in terms of the usual kind of interactions you have in clinic. So I'm going to just end my talk by highlighting some of the research studies that we have recently completed in our clinic and that we have ongoing in our clinic to share with you an idea of our interests. This was a recent multi-center study that sought to determine if neurocognitive functioning varied in ALL patients by whether you had prednisone or dexamethasone, or whether you had intrathecal methotrexate alone or triples. This is an important therapy question for us as we design future ALL trials, because ALL now, standard risk ALL, is now associated with 95% 5-year event-free survival. So what happens in 5 years and 10 years becomes very key and really does guide therapy. And so this study found that, in fact, neither of these treatment randomizations did affect neurocognitive impairment. And we use this information. Another hat I wear is as a member of the ALL task force, and as we're designing the next study, we were able to retain dexamethasone, which had long had the belief of having worse neurocognitive toxicity, but better survival. And similarly, triples are going to be introduced in the relapse group and some other groups without fear of long-term toxicity. Another recently completed study was a Sheila Senacroci's study on R21 to get preliminary data about whether phone intervention could increase self-efficacy and optimism in survivors who need to be motivated to have desirable health outcomes. And she was able to show that a telephone interview could do that, and also, which I thought was kind of cool, was that desirable health behaviors like not smoking and exercising and taking good calcium intake improved in both the control arm as well as intervention arm. So suggesting that even just coming to clinic did some good in that in terms of health behaviors, but did more good if you got telephone coping skills. There's an ongoing study now that's statewide with the Hartford hospitals that is in collaboration with Xiaomei Ma as one of our co-Is to look at adolescent and young adults with cancer. And the main thing is that this is a group that really gets lost and doesn't get appropriate follow-up, to see if we catch them 6 months after diagnosis and keep them in care and follow-up, that we can keep them through the survivorship period oriented to what their follow-up care should be. Another ongoing study is to look at genetic predictors of neurobehavioral functioning in cancer survivors. We are doing neurocognitive testing on all survivors and in our clinic, and then with the biological material, we're specifically interested if inherited differences in the serotonin dopamine pathway are associated with differences in functioning, as has been found in adult psychiatric patients who have cognitive deficits in very similar areas. And we have also constructed a retrospective database of our own Yale Hodgkin's patients with Xiaomei Ma and Ken Roberts that we're hoping to use as a resource. We're first doing a linkage with the Tumor Registry to see if we can document that the risk of second cancer has decreased now that we limited radiation dose and changed our alkylator regimens. And the preliminary results I'm not going to share here, but a little surprising. They haven't, say, in general, they haven't decreased as much as we would have thought. But we're also hoping to use this resource to study patients in the future and for other outcomes. So in summary, I'd just like to emphasize that cure is the rule and not the exception for children with cancer, and I'll add 2/3 of adult cancer patients as well, that childhood cancer survivors are at increased risk for medical, neurocognitive, and psychosocial outcomes that impact their quality of life, and that clinical and research efforts are needed to prevent and mitigate late treatment effects while preserving cure. I'd like to acknowledge these funding agencies, including the Connecticut Challenge and our HEROS team that's back here. Lynn Balsamo is our psychologist, and Tanetta Christie is our nurse coordinator. And I'll end with my license plate, so you'll know when I'm in the hospital. So, one of the early radiation oncologists said this, and it's true. I think cure is not enough. I think we're going to be redefining cure in the coming years more and more to take into account some of the factors I shared. So thank you very much.